Welcome, everyone. This is the first part of our healthcare series, a five-part series, and we just are so grateful that you're here and taking time and space for all of us. We're really talking about disability and healthcare and the transition from pediatric to adult healthcare. And it's a big leap. What we decided to do with this series as our team from the Transition Center was invite five expert speakers who will talk about diverse experiences, whether professionally or through lived experiences, or sometimes a combination, and talk about how to navigate healthcare. And I'm really excited about the speaker lineup. And today we're really starting off with a gem. We'll be talking about how healthcare systems change in adulthood, how to plan for continuity of care, how to also be able to learn how to communicate effectively. You're the best advocates, whether you're a professional here today or a parent or caregiver, and you want to know, how do I transfer this information to a different team, and how do we coordinate care? We're going to have a lot of practical tools. We're going to have resources, and we're going to have a dialogue. I do want you to use the chat to post your questions, and Dr. Trivedi and I will answer those at the end of the recorded, or rather the webinar. And speaking of recording, you will get a copy of this, so please don't take copious notes. Sit back and absorb what you can and come away with a few takeaways, because it's a lot today. But again, thank you, thank you, thank you. Next slide, please. And the next slide. Great, thank you so much. We have closed captioning if you'd like to utilize that, please. So today's session one, without further ado, seeing beyond behavior and agitation in IDD. And of course, this goes with ASD and any disability. It's a big leap for all of us when we have to have any kind of healthcare procedure. There's always a little bit of anxiety about going to a doctor and having examinations and having care. But we do know that people on the intellectual disability spectrum and autism spectrum sometimes face unique challenges. And sometimes those behavioral situations and challenges do impact access to healthcare. So today we've invited Dr. Trivedi from StationMD, who's going to talk about it. So let's turn it over right now to you, Dr. Trivedi. Thank you so much.
My pleasure. Thank you for having me in. Can you hear me okay? Oh, great, great.
Definitely.
First of all, I want to thank Anne, Janine, and the Perkins Center for organizing this. It's really been a pleasure working with them, and an honor to be here. Just a little bit about my background. I am a physician by training, emergency medicine physician, been practicing over 20 years in the New York area. And about 10 years ago, got involved in the disability community through an organization that I helped co-found called StationMD. Our mission at StationMD is pretty straightforward, and that's really to improve the quality of health and the quality of life for individuals with IDD, intellectual and developmental disabilities. We happen to use telehealth to deliver that care. We are in Massachusetts providing care to several organizations. We're in about 20 or so some states. If you want to learn more, you can go to our website. But again, my special interest is really in improving the quality of health for individuals with IDD, and also bringing innovation and technology to this often neglected community. It's a vulnerable population that's often overlooked when we talk about individuals that don't have access. So with that, we can go to the next slide. I'm just going to turn my video off to save some bandwidth and just check my notes. But as Anne said, what are we going to be talking about today? It's really going beyond behavior and understanding specifically that agitation in individuals with IDD. What is it? How do we deal with it? How do we understand it? And seeing beyond it and labeling it in the ways we used to in the past. Um, I don't expect you to leave here being an expert in all things agitation and knowing everything about people with IDD, but I do want you to take away a few points. I'm going to touch on some of the medications. I'm going to touch on some of the techniques. But if you don't take anything away, the one thing I want you to take away is that behavior or that agitation almost always, not all the time, but almost always is some form of communication. That individual is trying to communicate something through that behavior, whether it's something physical, whether it's something clinical, whether it is something that is emotional. Really want to you to understand. In older methodology was that this behavior or pathology was inherent to the individual. That's just the way they are. That's just how John is. For those of you that are old enough, and you don't even have to be that old, that this population was often segregated from the community. There was kind of a desire to control the individuals, really big use of seclusion and physical restraints, chemical restraints, and those old methods of dealing with agitation and behavior have really transitioned to new methods, which I'm going to touch on some of these, which are what we call trauma-informed approach, developing skills such as communication, de-escalation, so we can include individuals in this community and have them be self-determinant. Let them do what they want to do and have them live the best quality of life that they can. So again, the one thing I want you to take away, if there's anything, is that agitation is that individual trying to communicate. They may not be able to verbally communicate, they may not be able to express themselves eloquently, but if we just remember that, it oftentimes it steers you away from saying, well, that's just how that person is. That's due to their IDD. That's due to their intellectual or developmental disability. Next slide. So again, this is just a disclaimer. It's for educational purposes only. Always, consult your primary care physician and get medical advice. Every case is unique. We can't just put a blanket technique to solve all forms of agitation, and just always to consult your healthcare professional for guidance. Next slide. So this is just a video about our organization. I guess we can play this now. That's just to give you an idea of what we do as an organization. I think Anne can press play there.
My name is Gary Jr.
Gary is somebody that is very diligent about working. He mows lawns. His home is very important to him, and the access program is very important to him.
My name is Anthony. I like rap music, hip hop, R&B, classic.
We take care of individuals with intellectual disabilities. Due to the COVID pandemic, we struggled to get medications refilled by their regular doctors.
I'm not really used to go at a hospital.
A lot of our residents really experience a lot of anxiety, stress, just overwhelming. They're afraid of doctors or hospitals. An ER visit, they'd wait there for 4 hours. They'd be stressed. By the time they got there, they might need even more than what they just came in for because they were so upset at that point.
The emergency department is a very chaotic, it can be a traumatic place in general. But for those individuals that have sensory issues or maybe nonverbal, it's especially traumatic.
Yeah.
Thank you for letting me know that.
And with more than 90% of our virtual consultations, the StationMD doctor can resolve an individual's medical issue without them ever leaving home.
With StationMD, our mission is really to improve the care of individuals with intellectual and developmental disabilities, IDD. All of our physicians at StationMD are specially trained to treat this population.
Hey there, how's it going?
Whether it be minor falls, rashes, fever, even questions. Minor issues turn into serious issues if they're not addressed.
StationMD makes it possible to have a doctor available 24 hours a day, 7 days a week. Being able to do the visits in the home makes it so that way they're in their own environment, they're comfortable, and the doctor can actually see what they're like on a day-to-day basis.
It makes our job in the house very easy.
We have had thousands and thousands of virtual encounters with individuals with disabilities.
Hi, Anthony. I'm Dr. Lim. What can I do for you today?
Essentially, it's a video consultation or virtual consultation with a physician. We also have the ability to listen to heart and lung sounds using a Bluetooth stethoscope, and we also have access to the individual's medical records.
Do we need a refill on Mr. Jennings' medications?
How are you feeling today, sir?
I'm doing just fine.
This is huge. We feel like we are bringing a fantastic service to be able to see a real MD doctor in their home. They're available 24/7 to you. This program can be great for those in the metropolitan areas or the more rural areas that don't have as many doctor's offices available.
I really thought that it was an exceptional way to assist somebody with a medical emergency. They don't have to leave their house. It makes them feel really comfortable, and they get to see a doctor right on the screen.
Just call a doctor in virtual to find out what's going on. And once it's solved, you feel a lot better.
How are you feeling right now?
I'm feeling more relaxed and happy.
Alright, bye. That was easy.
It was very simple to do. We filled out the forms, and the next thing we knew, the iPad had arrived so we could contact the doctor's office.
We've seen impacts not just to the individuals, the patients, but really also to the caregivers, the family members, the staff members, the nurses who are really on the front lines taking care of these folks every single day. To make an impact like this on a population, helping people really enjoy their quality of life much more, and we're proud to be at the forefront really of what we think is a paradigm change in delivering care for people with disabilities.
Great. Thank you, Ann. Appreciate it. We can go to the next slide. And I think, was there one before this? I can't remember. I'm sorry. Nope, that was great. Perfect. So, let's just for those of you level set and what are we, who are we talking about? IDD, intellectual and developmental disabilities. Affects about 6.5 million individuals, according to CDC. Some people say it's up to 15 million. I've heard 8 million. Part of the issue is it is a spectrum of disorders. It's not just one diagnosis, so there is a lot of individuals. But in general, the definition is for a developmental disability is something that occurs before the age of 18 or 21 and usually lasts a lifetime. We're not talking about someone who's 40 and then got in an accident. This is usually from birth. Now, specifically when we talk about agitation, it is an extremely common challenge when dealing with this population. Up to 30% of individuals with IDD experience some kind of agitation or behavioral issue. Something like 40% of this population has a co-occurring behavioral diagnosis. And again, as you'll see, when I talk about agitation, it can be minor all the way to major issues. But again, in general, they say roughly 30% of the individuals will experience it and have to deal with it at some point. Next slide. So what is agitation? How do we define it? In general, the definitions are listed here. It can be anything from a minor irritation or being restless to severe aggression that's harm to individuals themselves, harm to others, self-injury. It could be physical, it could be verbal, it could be vocal outburst. All of these definitions of agitation in individuals with IDD they're more prone because of, again, what I said in the beginning is an issue with communication. And I simply look at it in our own lives. If you weren't able to verbalize how you were feeling, if you were hungry or had pain or wanted to do something and couldn't express yourself, imagine that frustration. And that communication, it really is what leads to this agitation and anxiety. And that's really what we want to address. And how do we address that is really what I want to talk about. Next slide. So the first thing I want to talk about real quickly is what I call the clinical causes. This is a simple mnemonic, but what I want to get at is the underlying cause of the agitation or behavior that they're seeing. Let's make sure it's not clinical in origin. In medical terminology, is there any organic etiology to what is going on? And that's very serious. Is this something that we can address clinically that needs to be addressed, because that is the first and foremost thing that we should be looking at. HERTS is this mnemonic, stands for head, urinary tract, reflux, and GI issues, thyroid, and seizures. And I'm going to just go through this quickly, but in general, this is a mnemonic that helps healthcare professionals, caregivers, really identify a potential underlying cause of this distress and agitation that you may be seeing. Again, the H is head. Think about that. Is this something that's a migraine or a headache or a hearing issue, pain or discomfort related to a dental cause, such as an abscess? It could be an infection that's causing an ear infection that's causing this. Again, vision is another one. Maybe someone has difficulty seeing. Maybe they're losing their eyesight. So think about that as a potential cause of this when we're talking about the clinical picture here. U is urinary tract. Obviously, a very big issue in the population that we serve. UTIs, especially in females, are very common. It could be a kidney stone. That's also part of the urinary tract, very painful. And obstruction. Whenever we care for individuals with IDD that aren't able to verbalize or aren't able to maybe even go use the bathroom themselves, we always measure what's called their I's and O's, their ins and outs. Maybe someone is blocked, they haven't urinated in a while, or maybe they're dehydrated. So think about urinary tract. R, reflux, very common in the population that we treat. Reflux is, gastroesophageal reflux, heartburn. Some of that's related to the body habitus of the individuals. Some of it's related to the medications that they take. Individuals with IDD are frequently on 8, 10, 15 medications. All of them have some kind of side effect where GERD or reflux is a common problem, as is constipation. I put this in the same category. Constipation in the IDD community and IDD population is very serious. Constipation, if it's not addressed, turns into bowel obstruction. By the way, UTI, if it's not addressed, turns into urosepsis. So another reason why we monitor, has someone gone to the bowel, had a bowel movement? Has it been a solid bowel movement? It's something that we should really think about when we're looking at someone's agitation. I've had many individuals I get a call about, like, Bill is really upset, he's cranky, he doesn't want to eat. My first question is, have they gone to the bathroom in a while? Have you checked? They had an appropriate bowel movement. T is thyroid. I put that in there because it is common. It's not common, I'm sorry, it's uncommon, but it can happen where it's hyperthyroid, which is very overactive or underactive. But more importantly is trauma. And when I say trauma, I'm talking about injury. I'm talking about, it could be emotional trauma. It could be psychological trauma, but it could be also physical trauma. That's another reason why when we evaluate someone, maybe they have ulcer on their back, or maybe they have a cut on the part that clothing is being covered. Again, it's challenging when you can't verbalize, but if you think about it, maybe you'll be able to identify it and address it. And then lastly is S, seizures and side effects. Seizures are very common in our population. And also with that, I would put a lot of individuals are on several seizure medications that can also have side effects. In general, the medications in general can have side effects, but these are just quick mnemonics that I like to use whenever evaluating someone clinically. Before we just jump to think that this agitation is this behavior is something non-clinical, let's make sure it's not one of these uh, clinical issues that's causing this. I'm not going to too much detail, but another Hertz mnemonic, and I can put this in the chat. The H is health issues. The U is unmet needs, hunger, thirst, fatigue. The R is routine. Whenever you disrupt someone's routine, they get agitated. Imagine if you didn't get enough sleep, or you couldn't watch your favorite show, or you're used to eating a certain food. So that disruption in routine or an unfamiliar environment can cause agitation. The T it's still trauma. I didn't change the T there. But again, think about psychological trauma, grief or loss, or being bullied or being mistreated. And then S, I instead of the clinical, I put in sensory or social. Again, difficulty expressing pain or understanding others, or just being frustrated from being unable to communicate. The S, sensory or social, can also be, again, an unrecognized sensory need. Someone who's, has anxiety, needs to touch something, they're tactile. So anyway, I can put these in the chat, but think about these quick mnemonics whenever we're looking at someone in terms of evaluating their behavior. Next slide. So I do want to address this because I think it's important. The unique challenges and vulnerabilities that are faced by this population. Individuals with IDD, and this has been documented in numerous publications and studies, are a much higher risk of abuse and neglect. Obviously, that abuse and neglect can contribute to agitation. This population has often been identified as a vulnerable population, but in my experience, often comes up after we exhaust everyone else. When we talk about vulnerable populations, people talk about people that are in food deserts, or they talk about people of color, or people who are lower socioeconomic status. You know what? Individuals with IDD are all of those, plus they have an additional issue of intellectual or developmental disability. The other thing I would mention here is because of the inability to communicate, this population often gets abused because they're vulnerable. And what I find is that they are often the brunt of other people's issues. Someone had a bad day and they take it out on the individual they're caring for. It happens. It's just one of those things that I want everyone to be aware of. We all get stressed and we all get upset, and sometimes we take it out on others. This population has been notoriously been targeted in that in some really terrible ways, but also just in some minor ways where they get abused. So it's just something to think about when talking about people with IDD. Next slide. So I do think it's very important that we take a person-centered approach here. For those of you who know person-centered approaches, what is it to that specific individual's goals, their desires, their needs that we should be aware of. It is not just a saying. It really makes a difference where if you get to know an individual's life goals. What do they like to do? What are their strengths? What are their abilities? What are their desires? It really will make a difference in terms of how you approach someone. It could be as simple as I know that, at 7 o'clock, Bill loves to watch Wheel of Fortune, and that's his thing. And if you know that and he didn't get to watch it, or it's around the corner to turn it on, it makes a difference. It is one of those things. Or if someone has a goal of becoming a cook, or someone has a real big desire to go outside once a day, really understanding the individual and a person-centered approach. Because the other thing, again, is really important is it's not one size fits all here. When we talk about individuals, we really are talking about individuals and individuals' goals and needs, just as you would with anyone else without a disability. I do want to quickly talk about a case to kind of identify some of this, and also to address some of the ways that we really look at how we assess an individual. Real quickly, this is a case of a 28-year-old female. We'll call her Sarah, woman with Down syndrome, mild intellectual disability. This is a real case. She lived in a living arrangement with two roommates, and over the course of about a month or so, she just been increasingly agitated, frequent bouts of yelling, self-hitting, just didn't want to engage in any activities. And her caregivers were really concerned about her well-being. That's the agitation that she was expressing. Now, in this specific case, a decision was made to do a comprehensive assessment. And what I want you to get out of this is there are ways that we can measure this agitation. Obviously, we can say, yes, someone's agitated, they're yelling or they're hitting, but there are specific personalized interventions that we can do. In this specific case, again, I don't expect you to become experts, but there was a functional behavioral assessment where a trained behavioral analyst conducted this analysis, observed Sarah's behavior, and in this case revealed that her main issue was she had difficulty communicating her needs, and also when her routine was disrupted. So a communication assessment was done. A speech language pathologist was involved to evaluate her communication skills. And of course, prior to all of this, a medical evaluation was done to rule out like those Hertz things that I mentioned. In this specific case, her triggers were identified as, like I mentioned, communication and routine disruptions. And the intervention in this specific case was she was provided with augmentative and alternative communication device. And that was as simple as a board that had like 10 or 12 different pictures on. If she was hungry, she could point to food. If she was tired, she could point to sleep. They also modified her routine. So her daily routine was modified. So there was a lot less unexpected changes, anticipating her daily activities. And finally, a plan was created here, where outlining those strategies for caregivers to use to address this. This is only for me to let you know that there is a way that we can really measure this agitation, quantify it, get in professionals that can really evaluate an individual. But a lot of this is really getting to know the person and what are their triggers, what makes them happy. And this was a real case. And in this specific case, her agitation decreased dramatically. She used her device. It was a simple board that she used. Her quality of life dramatically improved. And you know what? Her agitation really decrease. And this is just for you all to understand that a medical evaluation, a functional behavioral analysis, a communication assessment. I know that we're limited with resources, but whenever possible, don't write off the agitation as just, well, that's Sarah. That's just how she is. It could be something deeper. Take some time to really take a deep dive in understanding what those specific causes of that agitation are, rather than just jumping to treat the agitation without knowing. So, next slide. Again, this was the evidence-based assessment. Again, I don't expect you to know all of this, but these are just some things that I think you should be aware of. There's the MOAS, which is the Modified Overt Aggression Scale. It's just a way of measuring the individual's aggression. It goes into, like, self-injury, disruption to the environment, damaging property. There's also another one called Aberrant Behavioral Checklist. I will tell you that these assessments are done, but very little has been studied in the IDD population. These are usually done in other individuals, but there is some recent movement in using these scales in individuals with IDD. Next slide. So I do want to also talk a little bit about de-escalation techniques. I do think that's important for everyone to just at least be aware of. These are simple techniques like verbal redirection, a calming environment. Some of these may seem instinctual, but again, also goes back to that person-centered approach. You know that when the place gets chaotic or the music is loud, that's when Bill's going to really get upset. So go to a quiet room, calm. Could be the opposite. It's too quiet. Someone needs music. Someone needs background. So these techniques, when agitation arises, have been shown to be extremely effective. Not jumping right to restraints or medications or chemicals. And again, that effective communication can really reduce that frustration for that individual. I've already touched on some of those communication devices. Again, it could be as simple as a symbol board. It could be a card. I've seen crazy gadgets that can interpret speech for someone that has garbled speech, and it turns into legible speech you can understand, also into writing. There's a lot of cool mobile devices, but in general, these are de-escalation techniques that really make an impact on addressing that agitation. I have another crazy, I guess you could tell me into acronyms. I can put that in the chat box, but it's called the SCARED method, SCARED, for de-escalation. Let me see. So S is safe, so safe environment. C is calm, like a calming environment. A is affirmation. So like you would do in your children when they get agitated, instead of criticizing it, affirm it. Say, I know you're upset. I know you're angry. Let me see what I can do. R is back to routine. E was empathy, goes without saying. SCARE. D is just develop a plan. Again, I'll put that in the chat box. But that again helps me remember when you're trying to de-escalate a situation. What are ways that we can address this? Next slide. So lastly, I do want to touch on medication management. I will say that in my opinion, and hopefully everyone's opinion, it should be oftentimes the last resort. That being said, it is very common in individuals with IDD to be on multiple medication, including psychotropic medications. And I think it's good for those of you that are on this call to at least know the basics and just hear some of the medications that are used, because they are very common. And also, maybe they don't need to be used at all. I have found individuals that are on multiple medications from multiple clinicians, and they don't need to be on many of them. So and so had an episode years ago, and the doctor put them on a medication for anxiety, and no one ever took it off. Or so and so put them on a medication to help them sleep, and now they're really tired, and someone put them on a medication to keep them awake. And so they're on two opposing medications. So polypharmacy is a whole nother lecture I could give, but again, I just think it's important that we understand what medications there are and the side effects. And if we go to the next slide, I do want to talk about a little bit of more importantly than the actual medications, what I think is important for everyone to understand. As you see here, 40 to 50% of individuals with IDD are on psychotropic medications. That is not surprising in the the country we live in, with a lot of medications being the first line, but it is what it is. But I do think it's important that we look at this list that I'm going to come and talk to you. Again, an individualized approach, really understanding what that individual's needs are, what works for them, what doesn't work for them. It's not, again, one size fits all. Psychotropic medication, as I mentioned, I will touch on that a little bit later and give you kind of an overview. But a risk benefit assessment. Before prescribing a medication, a thorough risk benefit should be done in any medication. What are the benefits against the risk? Every medication has a side effect or an adverse effect, and it could be simple or it could be very complex. Whereas, gait instability, meaning having trouble walking, or an issue that could be very serious to an individual if it's not looked at. Of course, informed consent is, whenever possible, should be done from the individual or their guardian. Just again, back to the individual. Are they aware of what meds they're on? If they're able to make a decision, maybe they don't want to be. Again, let them decide, if they're able to, what the potential risk and benefit of a medication are. Baseline assessment. This is one of my kind of pet peeves. Many individuals uh, have never been given the privilege, or at least shouldn't even be a privilege, it should be the basic right of a baseline assessment, meaning what is that person without any medications? Maybe no one's ever seen them when they're not on any medications, or it's been years and years. So, conducting a baseline assessment of the individual's behavior before they're on medication, or what is it like when they're not on those? Now, I say that all should be done in conjunction with the healthcare professionals. Some of these medications you can't just stop abruptly. That goes for seizure meds, that goes for hypertensive meds, a lot of them. But a baseline assessment is important because, again, as I mentioned, that case, someone was put on a med because they acted a certain way years ago, and they're still on it, and they don't necessarily need to be on it. Of course, monitoring, evaluation, that's critical. Regular monitoring, evaluating, do they still need to be on? Track changes in behavior, both positive and negative, to assess an individual's condition and if the medication is effective. Also, maybe there's a new medication out there with less side effects. There are constantly new ones coming out. Next slide. I'm going to go through these pretty quickly, but again, these are all really important when we're talking about med management. What is the lowest effective dose? Do they really need to be on the highest dose of a medication? Just increases their likelihood of side effects. Again, reviewing regularly. I mentioned the side effects. The behavioral interventions. Again, really important. Medication, and again, in my opinion, should be used only in conjunction with behavioral intervention, or not at all whenever possible. So combining that med with some behavioral strategy oftentimes is, in my opinion, leads to the best results. Again, consent and advocacy goes with informed consent, and also having someone be the person's champion is critical, especially if they don't have family or a legal guardian that's their champion. Regular reassessment of that person periodically. Do they need to be on 4 meds for sleep? Do they need to be on 3 meds for anxiety? Again, all of this can be labor intensive, but really yields positive results. And really, when done on an individualized basis with the person's goals in mind, really makes a huge difference. Consultation with specialists, again, consider seeking specialists to evaluate that polypharmacy, seeing a psychiatrist. And then, of course, there's legal and ethical concerns. Just being aware of when prescribing those meds, making sure that informed consent was given and adherence. It wasn't long ago where individuals were thrown in an institution and given meds based on their diagnosis. Wasn't personalized in any way. So, again, something that I want you to all be aware of. Next slide. So before I wrap up, I do want you to, again, I don't expect you to become an expert or a pharmacist or an expert on psychotropic medications, but I do want you to be aware of some of these meds in individuals. These are, in my opinion, the most common meds used to manage agitation in individuals with IDD. So just that you are aware of those. The antipsychotic medications, these are your like Haldol, haloperidol. Really, there's typical and atypical. The typical ones have significant side effects and really are less commonly prescribed today. The atypicals are probably the ones that you're seeing, like risperidone. They are used now more because of the lower risk of what we call extrapyramidal side effects, like shuffling gait or like kind of a gaze. But those are very commonly used in individuals with IDD for agitation. Mood stabilizers, these are your lithiums, Depakote, valproic acid. These are used to manage mood swings and aggression, particularly those with bipolar disorder. These are important to be aware of because oftentimes they need levels. That's why we say, oh, did you have a lithium level? Because it only works in what we call a narrow therapeutic window. The anxiety medications, you've probably heard of these. These are your benzodiazepines, your lorazepams, Ativan, antidepressants. If you watch TV, you've heard these. There's an ad for an antidepressant like every 5 minutes. But these are what we call your SSRIs, your selective serotonin reuptake inhibitors, oftentimes used to manage symptoms of depression and anxiety in individuals, and also which can contribute to agitation. So that's something that I want you to be aware of. Beta blockers are often used in managing agitation, particularly in individuals with IDD who have a co-occurring condition like autism spectrum disorder. These are like your propanolols. These are important because they also have a lot of other clinical side effects. They can cause respiratory issues, cardiac issues. Um, Sedative hypnotics are some of the newer ones. Zolpidem is one, especially when sleep disturbance is involved in contributing to the agitation. And then I put in melatonin just so there are a lot, and melatonin is just one of a hormone that kind of regulates your sleep-wake cycles. But again, it often used to reduce daytime agitation. But in that same category, there's tons of supplements out there that people are taking. Some of them I've never even heard of, that could have an adverse side effect or could interact with a medication that the person's on. Whether it's a medication related to their behavior or not, it could be related to their asthma or their diabetes. So, again, not that you walk away as an expert in all of this, but really that you're just aware that these are these medications that are out there that oftentimes are used. Again, I can't emphasize enough, if we can avoid medications or use them in conjunction with some kind of behavioral intervention or de escalation, I think that by far is better than just throwing medications at the problem. Next slide. It may be the last slide. Yeah, I kind of touched on a lot of these already. Again, the main thing is really the decision to use medication should be really considering the individual specific needs, their co-occurring conditions, and then again, regularly assessing whenever possible. It should not be the first line. I think we have to talk about it when we talk about agitation because it is very common, but I just want you to be aware of it. I think, is there one more slide? I'm not sure, Anne. Yeah. So I do want to really emphasize this part is getting family involved whenever. I may be preaching to the choir here, but oftentimes when I talk about, for example, that baseline assessment, if someone is in a group home or they may be in caring for someone that doesn't know, reach out to the family. The family was like, oh, this is Bill. Bill always gets upset when A, B, C or happens. So they know the person better than anyone. So involve family or have family involved whenever possible. Again, those special training and special settings, that goes without saying. It really does make a difference when we get an assessment done by specialists. And then I guess would leave you with this, understanding the root cause of agitation isn't always that easy. Just think about yourselves, think about your partners, your friends. It's not always easy to tell when someone's upset, and sometimes it takes some digging. Now imagine trying to do that in someone who can't communicate, is nonverbal, who has other issues. It is a challenging thing, and I think it's really incumbent upon us, all of us who are advocates, who care about this community, to take that extra step and understand that person. What are their goals and needs, and how can we identify the cause, the root cause? Because what I've heard over and over, and it's horrendous here, is like, well, that's just because of their XYZ. That's because of his cerebral palsy. That's because of the autism. That's because of, and it's not necessarily that. In fact, most of the time it's not. So really understanding that taking an extra step to find the cause and the root cause of the agitation is critical. So I think that was it. Yeah. And I will open up to questions. I don't know if there was any in the chat, and I think, Anne, you may have some, or
Yeah, Dr. Trivedi, thank you. We had someone talking about a functional behavioral assessment, and someone collaborated on that question. And certainly those functional behavioral assessments to understand behavior are really helpful if there's a pattern. I really love what you said about, behavior is communication. And a previous webinar we did together years ago with May Pham, we talked about how to create physical environments that are supportive, whether it's sensory or different waiting room experiences. Is there anything that you can shed light on that really helps families kind of pre-pave those appointments? And how are there changes right now within the medical community working with people with disabilities and who have behavioral concerns? Are you seeing trends and changes?
Yeah, I am. First of all, again, I would again defer to family. No one knows the individual better than family member and what will trigger them. I will say some of the things that I've seen is, and that's partly what we do as an organization at my company is let's avoid going to the ER if we can, whenever possible. Can we address it? The pandemic, if there's a silver lining to the pandemic, it's shown that telehealth has really proven itself as a viable means of delivering care. I would argue for those individuals with IDD or have sensory issues or really don't feel comfortable outside of their home setting, it's even more valuable. Transportation is eliminated. Sitting in a waiting room for hours is eliminated. And again, for many conditions, those issues can be addressed using a telehealth modality. Now, if you have to go, what I have seen some trends is what they call autism-friendly ERs or decreased sensory ERs. I built one myself. I will tell you, in practice, those are usually the first spaces to go when the place gets busy because there's no space. So in theory, it's great. There's not the bells and the whistles and the people running around chaotic, but there are not many that are out there, but those that are there, they're wonderful. They also are staffed or should be staffed with what I call people who have a cultural humility. They're not like, why are you here for constipation? It's more like, I understand this is a real issue. They say, so they're educated on how to speak to individuals. One other thing that I found is when an individual with IDD comes, oftentimes they go right to the family member, the caretaker. They don't talk to the individual. And the individual's like, well, talk to me. I'm the one that's here. They may be able to communicate themselves. So there is some movement in that. But in terms of those modalities from an ER, I think they're challenging because it is an emergency department and many of them are bursting at the seams. So to devote section with staff, it is a challenge, but they are out there. I would recommend whenever possible avoiding it if you can. Now, you have to go, you have to go. I understand, but there are many modalities of using kind of a telehealth platform or a less severe. If there's an urgent care that's closer to your home, that's not as chaotic, those are some of the things I would recommend.
I want to really acknowledge the medical professionals that are here, Dr. Trivedi from Department of Public Health and other agencies, and also the people who are working in the advocacy community, because we want to hear your voice. We really want to know how we can shift change, because some of the attitude is very institutional and very archaic.
Yeah.
And a lot of families are still using sedation as a way to get their children and young adults into medical care. I know that some families are doing that and they're stacking services. So they're, doing the blood work at the same time and gynecological. But are you seeing a movement away from sedation? Is the medical community endorsing this still?
I mean, I am seeing a movement. I think it's things like this, and it's education and advocacy. This is a community that oftentimes doesn't have a voice, and I think that the more we talk and educate, I will say a few things. One, I think that it needs to go all the way back to medical schools and training. The statistic I throw out there is 13 minutes. That's 13 minutes in a 4-year medical school curriculum are devoted to educating future clinicians about individuals with IDD. So not too much training there. Unless you are a clinician that has either a special connection or you happen to be in developmental medicine or you have a big cohort of individuals that you care for, most doctors are not comfortable or trained to properly care for this population. And that's a fact. Uh, there was a study in JAMA or some publication where something like 84% of clinicians said they're not comfortable, nor do they want individuals with IDD in their office because they're they're challenging, they don't understand them, they're disruptive, they take longer. And let's be truthful, they're many times Medicaid, so they don't get reimbursed for caring for them. Imagine if that was doctors don't feel comfortable caring for poor people or black people or people with heart disease. It would be like front page news. But because it's IDD, it was a study that was published. So I do think it's very important that we work on education and advocacy. I do think there has been a shift from the way of just sedating and institutionalizing people. But, in this, not to get political, but in this environment, there's dramatic and drastic cuts to home and community-based services that are slated to happen. What's going to happen to individuals? Are they going to go back to the institution, back to the old ways? Many of these home and community-based services have been really beneficial, but it's if there's cuts, it's going to be really challenging for this community.
Dr. Trivedi, thank you for commenting on that. We've got some questions popping in. First of all, if there's any books that you're recommending, if you want to put that in the chat, anyone and Dr. Trivedi. I got a direct message that I'll read out loud. It's a little bit long, so let's see if we can dissect this. This individual's child has IDD, serious epilepsy, requiring 3 brain surgeries, many hospitalizations, MRIs, EEGs. The child or adult child perseverates on upcoming visits multiple times a day, months in advance, but demands to know when the next appointment is. So they're providing reassurance. They're on multiple meds. I don't know what the real question is, if you could add that in, but obviously we want to empathize with you. That's a lot and that's real heavy. How do you recommend, Dr. Trivedi, if someone has complex medical needs, and we have a community here of parents with that, how do you pre-pave that with your child, and how far in advance?
Again, not to divert the question, each case is so unique. Are we talking about a 5-year-old or a 15-year-old? What is their level of understanding? What do they enjoy? What they don't? From a broad perspective, I will say, if an individual is able to understand, the more information, the better. I think, not shielding them from the truth, explaining what's going on. But I would also say find a community or a clinician, or use a telehealth organization that can address this. And also find, if you can, a community of like-minded or other families that are going through this. But when it comes to the individual, it really, and I'd be happy to, I put my email in the chat. If you want to email me directly, I could answer that or help you go walk through that. I have found that using modalities like anticipating what, if an appointment's coming up, or avoiding the appointment completely. A lot of times doctors will put you on, I'll see you in 2 months. Yeah, but that may be fine for you or I, but 2 months for a family member with a child that has special transportation needs and they have to take off of work. Do you really need to go? I mean, maybe this could be done over the phone or be a telehealth, or really questioning those repeat visits or even seizures. Again, each case is unique, but studies have shown that not every seizure needs to be taken to the ER and addressed. In fact, most don't. So it really has to be a personalized approach, and I'd be happy to, speak to the person. Again, my email's in there if you have questions about any aspect. The
And
other
Jenny
thing,
talks about, extended medical hours, and I love that conversation, Jenny. And I think what Dr. Trivedi is saying is, it takes a conversation before these appointments with the doctor to say, look, what can we do virtually? What's absolutely necessary? And would you offer a different, appointment time? Is it better, a certain time? Really advocating. You've been doing it already for your child's whole life. So I think it's important to be an advocate in that regard. I wonder if being a mandatory reporter also plays part in this, that being there are parents with IDD and have higher statistics. I'm not sure what the question is, Nicole. So if you're talking about parents who have IDD on their own, how do you support them as parents? If you could clarify that, please. Some parents are just putting in some really great comments about using social stories, building community support within the community. using civic organizations like Lions Club to help advocate for medical needs. Is there an app to help those patients to help communicate in their doctor visits?
Yeah. And IEC is developing an app that the name escapes me. There's one or two out there for sure, where it is not, maybe doesn't fully out of what you mentioned, but it's an app that you bring to the ER, your clinician, that has all of your meds, everything listed, your behavior. Um, Shoot, I can't think of the name, but it is through IEC, and I can get that to you, Anne, to send out.
Okay, we can include that information in the recording.
Yeah.
Jackie Doherty and others are sharing, and some professionals, that the Operation House Call through the ARC is training future doctors and dentists in 7 major medical schools throughout Massachusetts. We're fortunate, Dr. Trivedi, in Massachusetts. We have Boston Medical Center, which has the autism program. We have Boston Children's Hospital, Laurie Center. For people in other states, if you want to drop some resources and share, and Dr. Trivedi, are there any other we have a lot of people in Colorado, Texas, and Arizona in our call today. So any
Yeah.
resources are appreciated.
Yeah, there are a few for Colorado. I work closely with the Alliance, which is it's an alliance of provider agencies that care for people with IDD. They have resources. There are, if you're fortunate enough to live near a clinic that does a lot of this, again, Massachusetts unique, I think, in having those resources. This is not the norm. And again, I would recommend you reach out to your local either your DD division of the state for resources, say they're state-based, but also national organizations such as the ARC, such as Anchor, which is an organization of provider agencies. And again, you can email me as well. I'm a little biased with telehealth, but I am telling you, I think that having advocacy clinicians that you can turn to quickly, that are specialized, that understand your needs, is absolutely critical. If I get a call for an individual and I can't resolve the issue via telehealth and I have to send them to the ER, I will call the ER myself, and all of our docs do. And that is huge because the ER doc appreciates it. They understand there's another physician out there that I can send them out to. So I think having an advocate and having someone that you can call for those kind of questions and concerns is huge. We're doing that in Massachusetts with Northeast Arc and a few others, and many other states. But yeah, well, again, these are state initiatives that we are, I think, working on. And the beauty of these is, given these tremendous cuts down the road, this is something that saves money because you're avoiding ER visits, you're avoiding hospitalizations, you're addressing constipation early and things like that. So, but yeah.
And Rob Harris, one of our biggest
Oh.
parent advocates, Empowering Dads, just dropped the app from IEC.
Yeah, that's the one. Yep.
Thank you.
There is another one out there, but I'll have to look. So yeah, thank you.
Great, great, great. Well, Dr. Trivedi, we want to thank you so much. And we all want to remember, Dr. Trivedi is based in New York, but StationMD is in how many states right now, or do you extend across the US?
We're in about 24 states. Yeah. We are in Massachusetts, not in Colorado yet, but yeah. Yeah.
All right, great, Dr. Trivedi. And let's stand by for a minute. Janine, if you could pop over a few more. Katie Shields talks about the Boston Medical Center, which I fully support. So first of all, we want to thank everybody for being here. I hope you have some takeaways. This is a lot to dive into. Just a couple of announcements we want to talk about. Our next one, I'll talk about, we have an in-person event on May 7th for people in the Boston community in New England. It's on housing, and I promise you, this is a gem. I like all of our in-person events that we do, but we know that you want to come together. So do save the date for May 7th in person at Perkins, and it's for all disabilities. Rob Harris, who's here today from Colorado, will be one of our speakers for Empowering Fathers, our May transition talk. And we do offer one-on-one guidance. I did drop my email address in the box. And I do want to say next Wednesday, April 8th, is PAP Camp with the Rowan Center from New Jersey. They will be talking about female gynecological care. And I really am excited about this one. Dr. Trivedi, please share within your community. I have some, private clients that have never had gynecological care, and they're in their 40s. And we all know with women anatomy, that's pretty scary. So definitely tune in next week. Next one, please. We have a Facebook group if you want to take a screenshot. And again, Dr. Trivedi and StationMD, thank you for your time. It was really an invaluable experience. I hope everybody has a great day. We'll see you next Wednesday, same time for our lunchtime series.